very pleased to have John Lochman doing the presentation on school-based violence and aggression prevention programs, what the evidence says. We're real pleased to have him do this because he is, as everyone else, one of the experts in the country in doing this, the developer of the Anger Coping Program and the Coping Power Program, and author of literally hundreds of studies on school-based prevention and intervention programs. So please help me welcome John Lochman.
What I'm going to talk about here today is very briefly, at the beginning, talk about prevention and treatment. So the presentations we've had here today so far have focused primarily on treatment, occasionally with some prevention coming in, but a heavy focus on treatment. And in my presentation, it's going to be reverse. We're going to talk a lot about prevention and then some on treatment. I'll talk about evidence-based programs, give you an overview of those. I'll talk a bit about typical elements of cognitive behavioral programs, kind of just abstracted out what are common practices that we would see in many of these kinds of programs. And then at the last part of the talk, I want to talk about the certain beliefs that we have about intervention with children who are pretty aggressive and have difficulties, and test it a little bit about whether or not some of those are myths or not myths. So I'm going to start here and think about prevention and treatment. And this is the continuum that the Institute of Medicine first came out with in 1994, and they've updated it more recently. And what's useful for our purposes here is that this is a continuum going from prevention to treatment. And in the prevention area, it starts down here with universal prevention. And we're going to talk a little bit today about some universal prevention programs. So universal prevention are programs that are delivered to everyone. So it's delivered in the classroom or delivered at the school level. It's not picking out certain individuals. But there are other forms of prevention as well, this indicated and selective, and those really represent targeted prevention. So those are intervention programs that are targeted at-risk individuals, and there's various ways to determine who's at risk. But in this model, one of the things to note is that as we conceptualize it in this way, we can see that intervening in a preventive way with at-risk individuals really moves into or is right next door to very traditional treatment. And a number of the programs that I'll talk about here today really then are used both for targeted prevention, but they're also used for treatment. They're flexible in that way. They can be used across. In your handouts, you're going to find a lot more detail about each one of these programs. In going through my talk here, just before coming, I realized that if I really went through each of the points on those charts, on those PowerPoints, I'd probably be up here for about an hour and a half or 2 hours, and that wouldn't be a good thing. People would start giving me the evil eye down here. So what I'm going to do is ask you to pay attention to, in your own handout, some of the summary material about these programs, because in that summary, it's going to provide you some information about what the relative effects are. Now, in going through these programs, I'm going to talk about them in 3 different developmental epochs. So the first developmental epoch is the one that's up here. These are programs targeted for children who have problems with aggressive behavior or conduct problems. The programs are focusing on the preschool to early elementary school age period. The second developmental epoch that we'll talk about is later elementary school, so later childhood. And then the third developmental epoch is early adolescence. And within each of these developmental epochs, I'm going to provide you with some examples of programs that could be used at that universal prevention level to everyone, or at a targeted prevention or treatment level just to select individuals. So here we're looking at some of the programs that have provided some research base for universal intervention. These are school-based, classroom-based programs. The Good Behavior Game is an interesting program. It actually goes back into the 1960s and 70s. And the early research on this was done at Johns Hopkins University in Baltimore by Shep Kellum, a child psychiatrist, and some of his colleagues. And this is a very traditional behavioral program. So it's not cognitive in any real sense. It's behavioral. And the way it's typically implemented, a classroom would be divided up into teams. So you'd be team A, you'd be team B. And the teacher would keep track of how many points you guys are getting versus how many points you guys are getting in terms of following classroom rules. And the team that gets more points gets a reward. So it's a very straightforward system. And what Shep Kellum and his colleagues found was that when these children were followed up into their early adolescent years, that there was an effect of this fairly simple early intervention program delivered in the early years of elementary school on children's aggressive behavior. And it was evident amongst those children who were the most aggressive back there in first grade or second grade. The second program up here is really quite different, and it's a really good example, I think, of the social emotional learning kinds of universal prevention programs that are available now out in school settings. So it's promoting alternative thinking skills or paths. The primary person on this is Mark Greenberg, who's one of the colleagues I have on Fast Track. And so in this program, the teacher, through training, learns how to deliver certain modules in the classroom. And they're delivered usually once or twice a week for 20 minutes to a half hour, and there's a lot of negotiation about how much time the teacher would have available for this. And the goal is to enhance children's emotion awareness, to enhance their emotion regulation, and then to help them do better at problem solving. And in some of the research following up this program at 2-year follow-ups, Mark Greenberg and colleagues have found that these children who receive this program in comparison to other children have greater emotional understanding, greater problem solving, and fewer conduct problems. The LIFT program from John Reed out of Oregon is yet a different type of program. So there are relatively few of the universal prevention programs that are delivered to everybody have a lot of components, but this particular one does. So it includes 20 classroom sessions directed at the children on social skills. And then there are parent sessions that are offered to all the parents in those classrooms. And then in addition to that, they take this good behavior game, this very operant kind of program, and use it on children's behavior during playground, recognizing that it's in playground time that there might be many instances for aggressive behavior. And what John and colleagues have found that immediately after the program, there's reductions in children's playground aggression and in family problem solving. And importantly, when they followed these children up years later into middle school, the children have fewer police arrests and they have less alcohol use. So it has, this kind of prevention program has some clear effects on very important outcomes at later points in time. Second step is another one of these programs. In some ways, it's a little bit like PATHS in that it's a very clear social emotional learning program, targets the same kind of skill set, is very widely disseminated, widely used in many schools, might be in some of the schools here. But unlike the first three programs, it actually has very few controlled studies that have been conducted on it. There is some research that suggests that it reduces observed physical aggression, but the findings are very mixed in terms of parent-teacher ratings of aggression. So those are the kind of universal programs for these younger children, either prior to school entry or in first and second grade. Well, what about programs that are offered to children who are either already at high risk or who are diagnosed and could be treated within a school-related kind of setting? And there are 6 programs here that I'm going to mention. First of those we've already heard about, so Incredible Years. Incredible Years is another one of these multi-component programs that Carolyn Webster Stratton has developed. Has some very well-developed and elaborated programs for parents, including basic training in parenting skills and then advanced training for working on parents' psychopathology and stress. And then in addition to that, there's this direct work with the children in the dinosaur school. We heard about that earlier, where children are taught through their teachers how to use problem-solving skills and how to improve in their emotion regulation skills. And across a series of studies, The Incredible Years has been found to produce reductions in negative parenting, improvements in social problem-solving skills, and reductions in conduct problems. And at a one-year follow-up, 2/3 of the children are within a normal range. So this is a program that had, in its research, was primarily being used in clinical settings, in clinics, outpatient clinics, but has been used in Head Start schools and other settings as a prevention program. Triple P, we've heard a little bit about that already. This is a fairly elaborate 5-tier intervention. What's really unique about this is that this is delivered within a community. So they would decide that Miami is going to receive Triple P, and at the very first tier, or the lowest tier, it would start out with a media campaign that would take place through your local TV stations and local radio stations about the kinds of parenting that good parents can use. And then that's followed by these tiers that have progressively more intensive intervention depending upon the problem level that the child has. And when you get up to tier 4 and 5, you're dealing with children who actually are pretty severely problematic at this point in time, and it kind of begins to blend into treatment at that point in time. The Montreal Delinquency Prevention Program is a program that Richard Tremblay and his colleagues used with 2nd and 3rd grade children, and had 2 components: working with parents in a behavioral parent training group, and then also there was a child skill component. And this is an interesting program because at the end of the intervention, there actually were very few positive effects that were noted. But when they came back, they were persistent, like many researchers are, and they came back to the same sample when these children were age 12, and they found at age 12 that in fact the intervened with children had significant reductions in delinquency and substance use at this later point in time, as those positive effects were maintained through age 15. So one of the things I think that we think about with prevention programs is that sometimes there are sleeper effects or late blooming effects that show up for programs. So you get things started at an early age, and then some of the more interesting and important findings come up later. It certainly did in this particular case. Bill mentioned Fast Track, so this is a program that I'm one of the co-investigators on, and unlike any other program here, it's incredibly comprehensive, much more comprehensive than any other treatment program or prevention program. We identified children in kindergarten, started intervening in 1st grade, and this preventive intervention continued all the way through 10th grade. So it's a very long-lasting program with many elements. It included the PATHS program for universal prevention, and then had targeted interventions for the parents, friendship groups for high-risk children, tutoring to help children with their reading, and as children got older, there were other programs like mentoring that were included. The findings here were kind of interesting too, in that there were pretty clear but moderate or medium, small effects in the elementary school year, but consistent from year to year, that there were reductions in these children's aggressive and disruptive behavior, and then improvement in their positive social cognitive processes. That was a target for at least the friendship groups with the children. However, once the children moved into middle school, the earlier gains were no longer apparent, kind of faded during that period of time. And it's only in the last year or so that we've now published some other findings on these children in high school, and have found that in high school, the intervention children do have lower arrest records according to the police records, and they have lower conduct disorder diagnoses, at least in terms of those children who initially were the most problematic. So I think the interesting thing here is that even these kind of long-lasting interventions can be kind of phasic themselves, and there are periods of time when children are probably less available and that the program was not matched to their needs. Family Checkup is a program that's almost at the other extreme end from Fast Track, in that in its base form, it's a 3-session intervention. This is a program developed by Tom DeShawn, and it's kind of based on the motivational interviewing technique kind of literature. And in this kind of program, a child and their family are brought in. There's a very full assessment done with that child and parent. And then the parent and the children are brought back for another visit. Family are told about what their strengths are, and then what are essentially the weaknesses, or what are the targets for intervention. And then fairly tailored or specific aspects of intervention are pulled out to work with them. And in this very brief intervention, Tom DeShawn, Danny Shaw, Francis Gardner have found reductions in disruptive behavior, and then importantly, improvements in maternal involvement. And I'm going to come back to this family checkup a little bit later in my talk. And finally, I'm just going to mention the parent-child interaction therapy, Sheila Iberg's program. This is a program that's important to note because of its very large effect sizes within this area. So studies have typically found medium to large effect sizes and reductions of negative behavior. But this particular program has been primarily used in clinic settings, and in only a couple of cases that I'm aware of has been moved into the school setting, but could be as a kind of a targeted prevention program in select cases. Okay, looking at later childhood, so here we're looking at children now who are moving into 4th and 5th grade, getting ready for that transition into middle school. There are several universal intervention programs that have been specifically developed for children at that period of time. Probably most notable is the Seattle Social Development Project. It's developed by David Hawkins, and this has a focus on training for teachers, training for parents, and then also social skill training with the children. And at the time of follow-ups, there are findings of children having lower alcohol use, delinquency, risky sexual behavior, and more commitment to school. So pretty broad effects as these children then move into middle school and later on. The bullying program by Dan Olvius gets a lot of attention because of our emphasis in the media and in our schools right now about this whole issue of bullying. And this program, different I think than other programs, focuses more at the whole school level, and it attempts to change school staff's attitudes and acceptance or not acceptance of bullying within their school. And when it's been implemented, it's produced up to 50% decreases of 50% bullying and decreases in delinquency at 2-year follow-ups. Findings for the bullying program have been strongest in the Scandinavian countries where Dan originally developed the program. They've become somewhat less strong, but still significant when it's been disseminated elsewhere. And then finally, this is a newer project, Positive Behavior Supports. This is also a more minimal universal intervention. And the focus here is on workshops with teachers and students focusing on enhancing the positive behavioral expectations that would be held in the school setting, and then provides reinforcement and rewards. So it's got some operant elements and has been found to reduce office referrals by 80%. I don't know if this is commonly available in schools here in Florida, but it's becoming very commonly available in many school systems throughout the country. In terms of the treatment or targeted prevention programs at this age level, we've heard about both these. So Al Kasdan's work with problem-solving skills training, and then with parent training. In his work, he has conducted very well-controlled studies with difficult populations, both inpatient and outpatient, and has found reductions in children's aggressive behavior, improvement in their social activities, and have found the disruptive behavioral problems to remain low at a one-year follow-up. The anger coping and coping power programs, in contrast to Al Kasdan's work, anger coping and coping power were originally developed for use in schools, and only in more recent years have they been adapted out and used in clinic settings and various places. And the findings here would indicate that at one-year follow-ups across separate samples, we have found reductions in children's delinquency and in their substance use and in aggressive behavior in school settings. We found that those findings are mediated through changes in children's social cognitive processes and parenting processes. And in some current analyses, we're finding that some of those effects are still there 3 to 4 years after the end of the intervention. So in early adolescence, once we move into middle school and high school, there actually are fewer school-based programs that have evidence base the further out that you get. At the universal prevention level, there are some, and perhaps most widely used of these is Gil Botvin's Life Skills Training Program. And in a series of research studies across a number of settings, there are consistent findings that this fairly brief program has 10 sessions, produces reductions in alcohol, tobacco, marijuana, and polydrug use. These other programs are Al Farrell's Responding in Peaceful and Positive Ways. This program has led to reduced school punishments and suspensions for violent behavior. It was really developed with the schools in mind when it first came out. The School Transitional Environment Project by Bob Filner. This is actually a fairly old program in the context of all these. It started also back in the 1960s, and it targets the transitions that children have between elementary school and then middle school and high school, and has program elements that focus on the child and the parents and the teacher, and has produced findings of 50% reductions in dropout rates, improved attendance, improved school achievement. And then finally, the Positive Youth Development Program is a newer program, and this program has produced changes in children's conflict resolution, impulse control, and peer relations with their peers. When we look at treatment and targeted prevention programs that might be delivered in the school setting, we find, this is where we really find very little. There are some programs like the Art of Self-Control that Eva Feinler has developed. It's a 10-session anger control program, has been used in juvenile justice facilities, in outpatient facilities, certainly could be used in schools because of its structure. It's a small group intervention. The most well-known and the most well-founded programs like MST and then Patty Chamberlain's multidimensional treatment foster care are really not the kinds of programs that would be delivered within a school setting, although because of their breadth, they do have some elements where the therapists are expected to connect with and impact with teachers and with other school personnel. So what we've gone through here rather quickly are a range of different programs, and as we talked, there are some of these programs that are essentially more behavioral, and some that are more cognitive, and some that have both behavioral and cognitive elements. Most of these programs, except for the really behavioral ones, like the Good Behavior Game, address children's cognitions, emotions, and behavior, much like we've talked about today. And there are certain common elements. I'm going to mention these. These are common elements that we draw from our work with coping power, but they show up in varying degrees in these other programs as well. So the first kind of element that shows up in these type of programs is a focus on helping children to better goal set, to identify long-term goals for themselves, and then to identify short-term goals that can help to make those long-term goals possible. And in many cases, the short-term goals are thought to be pro-social opposites of the problem behaviors they're currently displaying. So it's something, if they get better at that goal, then the problems will begin to decrease. And we take those kind of goals, short-term goals that kids have, and they are then used on goal-setting sheets that the teachers or parents monitor on a daily basis, come back to the group, and children receive reinforcement for their goal attainment. We do think that this kind of program likely leads to a greater focus on the consequences of children's behaviors. They pay more attention to consequences, and outcome expectations that children have are a key mediator of intervention effects in this area. We also have some fairly direct evidence that if you don't include some type of goal-setting component like this, the effects from your intervention work are less likely to generalize into the classroom setting. Many of the kids that we work with have concomitant academic problems. It's been a theme, I think, for today about comorbidity, and certainly from Chris's work, we've heard about some of the kind of behavioral problems that children have who also are having academic problems. So it goes the other way as well. In these kind of programs, there can be fairly brief units that do focus on some issues. They might focus on study skills. They help children to identify good study skills, bad study skills, and then to think about how they're going to very concretely use some good study skills this week. What's my plan, what I'm going to try out, and report back how they work. Another common tool is to have the children and parents work together to create a homework contract in which very concretely it's identified where would homework be done and when in the school, in the home setting. How is homework completion going to be monitored, and what kind of rewards or consequences would develop for that. So there's an opportunity for both children and parents to negotiate. Awareness of emotions. So we were talking about many of these being social emotional learning programs. So emotions is a very common topic throughout these programs. And there's a focus on helping children to more accurately identify other people's emotions, but also to become better at identifying their own emotions. And we find in our work with aggressive children that we typically will start by having them talk not about anger, which is in fact the most relevant emotion, but what are some other broader emotions they experience, emotions related to vulnerability. And many of the children we work with, in fact, have difficulty conceptualizing when it is that they're really scared of things or frightened and are guarded in talking about those kind of emotions. So we work on those first and then move into anger. We typically will use tools like an anger thermometer as a central device when we're working with children in this area. And we want to use the anger thermometer as a way to help children to identify different levels of anger they experience, what they're experiencing when they do have that level, what kind of physiological reactions do I have, what kind of thoughts do I have, and then what are the triggers that develop for these different levels of anger. This kind of focus on anger management then leads directly into a focus on self-regulation. So what do you do about it now that we've talked about being angry and being triggered by different events? So anger management skills training is one of the common features of this type of work for children. And in our work and in many others, the children are helped to work to cope with their increasing arousal and to use techniques like distraction, or to use relaxation methods, or to use cognitive coping strategies, statements, to manage their arousal when they're faced with difficult events. We go through a graded series of activities. So over the years, I've begun to think about this as being more like exposure therapy, because we're really beginning to place children into situations where they become emotionally activated in ways that they can't control, not unlike anxiety, in fact. And so the intervention then involves placing kids in situations where that arousal can arise, but to do it in very graduated ways. And so we usually start off with third-person indirect activities like puppet role plays, but then move into live role plays where children actually practice skills. Some of these programs also include a focus on perspective taking, and when we're doing this, we start out with pretty fun game-like tasks where you realize that somebody else might see this picture or event in a different way than me. And then we begin to tie it into children's social interactions and social problems. And the goal here is to, with the children we work with, is to attack the hostile attributional bias. So the hostile attributional bias is this tendency for reactive aggressive children to assume that other people are about to do them harm or are doing them harm even when that's not warranted. So they're oversensitive to those kind of cues. And by focusing on perspective taking, we're trying to address that, to do attribution retraining in this particular area, and to help children to begin to recognize that sometimes it's hard to tell what other people's intentions are in these ambiguous situations. As children become better at recognizing other people's perspectives and intentions, then it's time for us to move into social problem-solving skill training. Social problem-solving skill training along with anger management are the most common features of intervention for children who have these problems with aggressive behavior. And children learn a stepwise series of ways to deal with problems, going from problem identification to generating solutions to considering consequences and to them making decisions about how to enact. We find that in doing this, there actually are a number of subtleties that it's important to work with children on. So rather than problem solving around the actual problem that occurred, which often generates a lot of heat, a lot of feeling for the children, we attempt to have them identify the goal they would have in that situation and try to shape that goal so it becomes somewhat less toxic and somewhat easier to get good solutions for. We also are working, as we go through problem solving, probing with children about how angry they would feel. And when we first start doing problem solving with children, we're going to start off with situations where their anger is pretty low on their anger thermometer to make it more likely that they can learn the skills. Basic assumption here is that emotion floods their cognitive processing abilities. So we're going to build that up, but at least at the beginning, the emotion needs to be at a lower level. We also do a series of activities within this area of work. So we have discussions, we have game-like tasks, we have role-playing, and then we found that having children audio record or video record role-playing is very helpful. These are children who often struggle at remaining enthusiastic and involved in intervention, and this is a tool to keep their motivation and enthusiasm going and also gives them a way to observe themselves as they're role-playing. And then finally, as children become better at social problem-solving skills, we particularly are focusing on social skill training and then targeting that as children move into the middle school age period on how they can deal with peer pressure, and then perhaps most critically, helping them to identify less deviant peer groups that they can be involved with. We know that the single most critical risk factor for a middle school age children, aggressive child, in terms of predicting whether or not that child's going to have serious delinquency in alcohol use, severe antisocial behavior, is whether they become involved with a deviant peer group during this period of time. So it's a very important part of intervention. Okay, so what we've done is we've talked about a range of programs, we've talked about some common elements, at least in a general form. I'd like to turn now to talk a little bit about some of the beliefs that we have about intervention. So we're very interested in dissemination, how you take programs to scale in school settings. And as we do that, we often have certain beliefs, and some of those beliefs are, in fact, possibly myths. And I'm going to explore the mythsness of some of these beliefs through some of our own data. And there are 7 myths here that I'd like to try to get through if I have time. 7 belief areas. The first is one that we've really touched on several times today. It's an interesting theme, I think, that's evolved. And so a belief is that multi-component interventions are more useful than simpler single-component interventions. And most of us must believe that because we keep creating these multi-component interventions. So somewhere we think that that has to be right. We know that there is some evidence in this area of children who have aggressive behavior or conduct problems that there's at least some cases where multi-component interventions have done better. John Weiss talked about some of the work from Carolyn Webster Stratton earlier today. So that was an example of a program that at least showed some promise for having a focus both on parents and children. Some of Al Kasdan's work has also gone in that same direction. We've also addressed that issue, and this is a study where we identified 183 at-risk aggressive boys in elementary schools in Durham, North Carolina. And these boys were randomly assigned to one of 3 conditions. They either were in, they received treatment as usual, they were a control condition. They received whatever the school would ordinarily provide, or they were randomly assigned to receive just the child component of coping power, or they received the full program. This was a study where we weren't able to get funding to do just the parent component by itself. But what we found when we came back 1 year after the end of intervention, so this is an important time that things stick for a full year with this pretty difficult group of participants, we found, in fact, there were reductions in delinquency and substance use with pretty reasonable size effect sizes. But that occurred only if the parents were involved. So if we were just working with the children at this 1-year follow-up, we were not having effects on delinquency and substance use. So it argues for the importance of that extra component if you're working with the children. However, interestingly, when we looked at what children were doing at school, this is at a 1-year follow-up, teacher ratings conducted in that follow-up year by teachers who were blind to what the original treatment condition were, that there were significant effects for intervention, and it didn't matter in that case whether or not the parent component was added or not. So it would suggest, in fact, that there are some outcomes that can be had just from the child intervention. So is this a myth or not that multi-component interventions are important in this area? It's not a myth for these kind of important outcomes in the community like delinquency and substance use. But it might, in fact, be a myth for school-based interventions if your goal in particular is to try to focus on children's behavior in the school setting. Booster sessions are necessary. This is another one of these things that we always think has to be. You know, we've done this amount of work, so a few more sessions must help to make it even better. A remarkably understudied assumption from an empirical standpoint. Very few real empirical studies of this phenomena. There's a couple of teaser effects, and one of them actually comes from one of our earlier anger coping studies where at a 3-year follow-up we found that some of the observed improvements in children's disruptive behavior in the classroom occurred most when those children and their parents had a booster, a very brief booster intervention. But that was, children weren't randomly assigned to the booster, so it was very preliminary. And then more recently, Pat Tolan in 2009 has just had a study where he found that a family-focused prevention program for children who have problems the booster did have an effect on children's aggression at a 1-year follow-up for at least children in general. However, there's other literature that would suggest that may not be true. Some of it's controlled research with adults in this Hodgins study recently, and more telling for the work we have here, it's the Donick study which found that boosters didn't really help a classroom social problem-solving program to reduce aggression. So we've been interested in this issue and pursued it by implementing a brief version of coping power in a school where we could, it's about 1/3 shorter than what we usually do. And we followed children across 5 annual assessment points. Between times 1 and 2, the intervention was delivered. between times 2 and 3, a booster was delivered to a randomly selected group of children who had the intervention, and then we followed them all up, including the control group, through time 5, so fairly lengthy follow-up. And the good news for just the Coping Power program was that if we offered Coping Power with this abbreviated version, there were significant effects on teacher-rated externalizing behavior problems through a 5-year follow-up. But when the booster was added, actually things were less strong. And it looks like this, so that the steepest decline here in slope is Coping Power by itself. This red line is Coping Power plus booster, and then that's the control group. So we could see that over time, Coping Power is continuing to have growing effects across time, well past the end of intervention. So some skills are learned, it appears, and kids actually develop and use them. But there's something about this booster, did not have parent components, that might have been an issue, that actually certainly didn't help. So is this a myth or not? The boosters are important. Well, I don't think it's a myth for preventive family interventions. I think the work Pat Tolan would suggest maybe that is useful. But for school-based interventions, I think it's still quite unclear. Interventions are most effective in higher socioeconomic neighborhoods, that kids who are coming from neighborhoods and areas where it's higher SES, things will go better. There's a fairly extensive literature at this point that's emerged really in the last 10 to 15 years that have found that neighborhood factors really do have an effect on children's aggression, independent of intervention. So children who are growing up in neighborhoods where there's more violence begin to show more aggressive behavior problems, and these negative neighborhoods are impacting not only the children's behavior, but also the parents' ability to accurately parent well, and has an effect on that whole sequence. So the question is whether or not disadvantaged neighborhoods might moderate intervention effects. So to look at this, we took a sample that we'd worked with back in Durham, North Carolina, and we identified 22 aggregated census tracts throughout the county, and identified where our sample was at, and then based on census data could identify some census tracts that had more disadvantage and some that had less. And when we looked at a teacher rating of aggression, so the TOCA is a teacher rating that teachers make of all the children in their classroom, we found in a model here, this is a HLM model where we're nesting children within the neighborhoods that they're in, that in fact there was an interaction effect that emerged between neighborhood disadvantage, treatment, and then time. And in this case, it's actually the square root of time, so it's a curvilinear effect. And it kind of looks like this. And the two dashed lines up here at the top represent neighborhoods that are have more disadvantage. And the red line is coping power, blue line is control. We can see that actually coping power in these bad, more problematic neighborhoods does have some effect, but begins to level out the longer we go. So this is like a 4-year time period. So the farther out we go, looks like neighborhoods begin to come back in and reduce the effect of intervention. But if we look at children who are within better neighborhoods, which are these two solid lines, children who have coping power have intervention effects that continue to grow across time. They don't stop, in contrast to the control group. So it would suggest, at least within this kind of a intervention that we're delivering here, that probably there is some advantage for children who've come from better neighborhoods. It means that we need to think about how this kind of program can be augmented and in different ways, other ways, in other neighborhoods. So is this a myth or not that interventions are going to do better in good neighborhoods? And I think it's really not a myth, at least from what we know at this point for these kind of school-based interventions. A myth or not, group interventions with aggressive children are necessarily always iatrogenic. So this is a great topic for any of you who work with kids in groups, right? I'm sure you all have your own beliefs about this. And so we're interested in this really quite a lot because all of that earlier research that I described that we've conducted on coping power was talking about an intervention that's delivered in a small group to children. So we're very wondering about this issue. And we've, in general, have found that coping power, the small group intervention, doesn't have iatrogenic effects of the sort where the kids get worse, but it's quite plausible that it's dampening or lowering the effect sizes that might have occurred if we didn't have the children in the groups. And why do we think that? Well, there's a large literature in developmental psychopathology that suggests that deviant peer groups make things worse for kids. So the steepest growth of substance use occurs among adolescents who are hanging out with drug-using peers. Similarly, in some of our own research, we found that if you take aggressive children and you examine as they move into a new set of classrooms the next school year, if you check children who've moved into classrooms who have a dense involvement of other aggressive children in that classroom, that their own aggressive behavior is going to increase during the course of that year. So they're sensitive to changes around them. And of course, the most important finding that in this area in our field comes from the work of Tom DeShawn. And back in the mid-1990s, so 15 years ago, he ran a study which was a prevention study for substance use with 7th grade children, so children who were into adolescence. And he found at 1-year follow-ups and at 3-year follow-ups that not only did that intervention not help them, those kids, in comparison to control children, they actually were worse. They had higher levels of substance use, had higher levels of delinquency than did the controlled children. So it was a very sobering finding. And Tom is a wonderful researcher, and one of the things that he did was to go into his tapes of sessions and was able to identify some of the very minute, small processes that take place in these type of groups that then predict this. One I think that most of us know about is something called deviancy training. And that's where if a child starts talking about using weed at home this weekend and other kids kind of smile at that or laugh at it, well, that's reinforcement for that and makes it likely that that child, just those events, those small events, make it more likely that child's going to start using substances down the road. So it's a very powerful effect. And we've decided to look at it. We actually have a R01 that's going on right now with Tom DeShawn as the co-investigator. So if you're interested in this phenomena, you want to get the guy who's the real deviance trainer himself. And we don't have the results from the large study, but to get the grant, as we all know, we have to do a little mini study first. And so this is the mini study. And here we took a brief version of coping power and we created an individual version of it and a group version. So even though there's this strong concern about deviant peer effects, there are virtually no studies in the field where you've used exactly the same intervention and then delivered in one case individually, the other case in group, right? So what we know of it really comes from studies where there's different kinds of interventions being delivered. So this is an effort to really address that and examine that. So here we were looking at children across from time 1 to time 3, which was at the very end of this intervention. And I'm going to show you 3 outcomes. 2 of these are child-based and kind of surprising in a certain way. So in this case, the blue line going down is children who are in groups, and these are children who are seen individually. The outcome is dominance and revenge social goals, so it's a good thing when that's going down. The kids are less revenge-oriented, and actually the kids who are in groups had more of a drop in that. If we look at children's self-regulation, their ability to regulate themselves affectively, behaviorally, cognitively, it's a similar picture. So the children who were in the groups, here at the blue line, are going down, so the dysregulation is dropping, in contrast to children who were seen individually. But if we look at kids' actual behavior, this is parent ratings of children's conduct problems, the finding is reversed. So here, the drop in parent-rated conduct problems is occurring with children who were seen individually and not so with children who were seen in groups. So, I think that what we could conclude from this very small study, which I would take with a grain of salt, I don't think it's representative. I think we'll know more from this larger study. But it begins to suggest that, in fact, an individual version of this program probably is going to have more effect on children's behavior than would a group version. However, there are some interesting things happening within a group that are within the child that may have some impact on follow-up. And so it's going to be important to examine through follow-up what happens. So is this a myth or not? It's not a myth, I think, for children's behavior, but could be a myth for other characteristics of the child. I think one of the take-home messages right now is not that that we have to abandon all forms of groups, but it does suggest pretty strongly that as we implement groups, we have to pay very great attention to what we do as leaders to try to reduce that deviancy training that goes on in the group. So I think there are a lot of skills that we need to learn as group leaders. Parent engagement and preventive intervention is only a function of parent characteristics. So we've heard some hints of that parent attendance is really due to who they are, what they are like. And we've looked at that a little bit, and we have some data that would suggest that too. So we're interested in contextual factors, and these are things related to maternal depression, family poverty. We find that these contextual factors have an influence on parents' attendance in the parent group as it's mediated by aspects of parenting that's already there at time one. So the parents who are more positive with their children attend more, and positive parenting is influenced by lower levels of these contextual factors. So that's kind of a sobering conclusion. You'd say, well, the parents who need it the most are the ones who are not going to come in very much here. But do we have to stop there? And I would suggest not. So I'm going to, if we go back to the family checkup, the notion, the thing that we talked about that Tom DeShawn has been developing, this very brief intervention, one of his findings, it's very clear, is that families who are involved in family checkup attend better after that. They engage in intervention better. So I think that if we can implement programs like family checkup, there can be a positive effect. So what is family checkup? It's a very simple intervention. We assess a variety of factors related to youth behavior, family behavior, children's involvement in schools, and in the feedback to the parents, there are a couple of key steps. One is that for every single family that I give feedback to, I'm going to find at least some strengths. So it's a strength-based feedback, which is part of what helps to motivate them to come back. They're realizing we're not only talking about the problems they have, but we're going to, from our assessment, find at least some things that are relative strengths for that family. And then we're going to take the things that are identified as difficulties and use those as targets to then identify fairly specific interventions or components of interventions that we would use with them. It's an adaptive intervention. It's a small version, really, of what John Weiss talked about earlier, but it's very focused on this particular area. So it could be that you could focus on parents and maybe have some effect on their attendance, even despite their characteristics. But it's also the case that child themselves could have some effect, potentially, on parent engagement. So this is a study that we're currently involved with. It's out under review. And the parent here, this is parent attendance early in intervention, middle of intervention, at the end of intervention, pretty good stability across time. And then this is child attendance and child engagement, their points they're getting in their group, and that's pretty consistent across time. But the really interesting thing is this right here. It's really pretty cool, because it suggests that how engaged the child is early in intervention is actually predicting improvements in parent attendance by the middle of the intervention. So the more that the kids are engaged, parents are picking up something and they become better at attending. So if we can target kids and hook them in, that makes it more likely that parents are going to come in. And of course, that's one of the assumptions here is that parent involvement is very critical. So is this a myth or not that parent involvement is only due to factors that are related to the parents? Well, in some ways it is. We have evidence that parent characteristics are important, but we also know that those parent attendance is manipulable. We can do something about it through interventions like the family checkup, and we can do something about it by engaging the children. Okay, I've got two other myths here, and I realize my time is either out or almost out. But let me tell you at least quickly what they are. So the one thing is related to the issue tomorrow. So a good basic workshop is sufficient training for school staff to implement prevention programs. That's a belief. Just have a good workshop. We have good workshops tomorrow, and that's all we need. Things will be fine. So what we've done is, in this study, it was a dissemination study in Alabama. We went to a lot of schools. We were in 57 different schools in Birmingham and areas around it, and randomly assigned the counselors in the schools to either receive treatment as usual, so they didn't receive training in coping power, they received basic training in coping power, or they received intensive training in coping power. And for basic training, they had a workshop and then some brief monthly follow-ups. The intensively trained counselors also had technical assistance, and then in a real critical way, they received some feedback from some of the audio tape sessions they had. So that was intensive. Did it make a difference? Well, if we look and just contrast in this kind of HLM model, contrast the children who had been worked with by those intensively trained counselors versus control, there actually were some pretty nice effects. And that was important because these are counselors, only about 20% of these counselors had used any type of manualized intervention prior to this. Very few had a background or basis, foundation in cognitive behavioral intervention. So for these relatively inexperienced counselors, in fact, there were positive effects, and there were reductions in teacher report, parent report, and child self-report of externalizing behavior problems. Good findings for taking something to the real world. In addition, teachers were reporting these children as having improvements in social and academic behavior, and the children had reductions in their expectations that aggression would lead to good outcomes. So all that was good. But when we look at the children who were worked with by basic training, counselors who received only basic training, the picture's different. So those children did show some improvements in positive skills, but no significant effects on some of the negative behaviors they had. So good news is you can take evidence-based programs out to real-world settings. Things can really change. Things can be good. But the intensity of training is hugely important, at least for this type of intervention with these kind of counselors. And it's likely that ongoing supervisory feedback is important. So that's a myth. So the last thing, and this is something for all of us to think about, the characteristics of schools and school staff affect the implementation of programs. And I couldn't figure out if that's which way to frame that. Is the belief that they would or they wouldn't, because I'm not sure how most people believe that. So I framed it this way. Using the same dissemination study, we asked the school counselors to fill out the NEO 5-factor inventory. So we looked at personality dimensions of neuroticism, extroversion, agreeableness, so forth. And then at the school level, we had the 4th and 5th grade teachers rate their school environment on 3 dimensions. So how rigid is your principal? Is the managerial control? How much professional autonomy is there? So forth. And we find that implementation, in fact, was in fact, as measured by number of objectives completed, number of sessions scheduled, was affected by 1 personality dimension. So counselors who were more agreeable, So agreeableness as a personality dimensions is related to flexibility and to ability to self-regulate your own stress, your own emotions. So counselors who did that better implemented better, and counselors who are in schools with less rigid managerial control implemented better. So your school makes a difference. We also looked at the quality of implementation, and quality of implementation in this case was derived from those codings, those audio tapes of sessions, and we coded them for just how well staff, the school staff intervened with children and with parents. And we again find that agreeableness predicts, but also conscientiousness. So the more agreeable, the more conscientious the counselors were, the better the program was implemented. And then we found two interactions between aspects of the school environment, how much professional autonomy is given and how much managerial control is given, and cynicism. So in addition, we asked counselors about their cynicism about organizational change, about basically whether or not these kind of programs work. And so what does this interaction look like? It looks like this. So the dashed line here are cynical counselors. And if you're a cynical counselor, highly cynical counselor, and you're in a school that permits low autonomy, you don't implement well. However, if you're a highly cynical counselor and you're in a school that permits high autonomy, you do fine. So think of your school as a protective factor. It's a contextual factor that helps to frame what we get. So is this a myth? Well, the good news, it's okay to be neurotic, not particularly open-minded, not particularly extroverted, and cynical if you are in the right environment. So that covers me anyway. It might cover many of us here. That we're okay, you know, we don't. However, the degree and quality of implementation can be influenced by certain dimensions related to agreeableness and conscientiousness, and it's certainly led us to try to think more about this whole dimension of agreeableness and what that's about and why that would be so critical, and also how the school environment plays such a role. So we would end that with not a myth, and I'm aware that I'm over here, so thank you.